Good morning, everyone. Welcome to week 2 of Cardio-ECHO, Tackling Type 2 Diabetes. I'm Jessie Lewis, the clinic coordinator, and I think with that, I will go ahead and turn it over to Dr. Dungan.
Hi there, I'm Kathleen Dungan, an endocrinologist at Ohio State University. So good morning. I will be facilitating the session today, and then I would like to have the rest of our hub team today that is going to be participating introduce themselves.
Thank you, Kathleen. I'm Goutham Rao. I'm the director of the ECHO program for cardio.
Hi, I'm Liz Beverly. I am a co-lead of the data and evaluation team for cardio, and I'm at Ohio University Heritage College of Osteopathic Medicine.
Hi, this is Sherry Boland. I'm a general internist at the Metro Health Bedford facility.
Great to have you with us. Okay, so here is an overview of the structure of the ECHO clinics, a little bit similar to last time, except a little bit more time to discuss our didactic presentation, which will be about 25 minutes, give or take, with some Q&A. Just remember that when we're doing the Q&A in particular, we'd love to see your shining faces, so please turn on your cameras, and you can either unmute yourself and discuss in person whatever questions you have, or alternatively, you can go ahead and use the chat feature. And that will be followed by the case study presentation and discussion. And then we'll have a wrap up. So let's get started. These are our disclosures. These were sent to you by email, I believe, yesterday. And today's discussion is going to be on health literacy and numeracy and its impact on type 2 diabetes. You'll notice that this was just a little bit off of the original planned schedule, so appreciate everyone's flexibility in making this happen today. This will be presented by Liz Beverly and Goutham Rao. So Liz, will you be going first?
Yes.
All right, take it away.
Thank you, Dr. Dungan. So today, these are our objectives. The first one is to describe the scope and impact of low health literacy on self-management of type 2 diabetes. The second objective is to define patient numeracy, and the last one is to describe the impact of low patient numeracy in the self-management of type 2 diabetes. So health literacy, as defined by the Institute of Medicine, is the degree to which people have the capacity to obtain, process, and understand basic health information, as well as services to make appropriate health decisions. So there are some recent systematic reviews that have looked at health literacy as it relates to type 2 diabetes specifically, and you can see those references down at the bottom. And there have been a lot of health literacy studies as it relates to diabetes. Given all of the self-care challenges that people with diabetes face, it involves a lot of health literacy following those behaviors when we factor in taking medications, going to routine clinical appointments, in terms of diet and exercise as well. And so you can see here with all of these different studies, the global prevalence of low health literacy in adults with type 2 diabetes is slightly over a third. And then the studies that have looked at it in the United States, the prevalence is approximately 29%. So factoring this in, it's about 1 in 3 people globally, as well as approaching 1 in 3 people in the United States. So we have very, very high rates of low health literacy globally, as well as in the United States. What I do want to mention and point out here is when we're talking about low health literacy, the research shows that education mediates the relationship between health literacy and health outcomes. And what this is saying is, if you have an individual with type 2 diabetes, the more education that they earn, so the more years of education that they have, what that does in the relationship is it improves the health literacy and leads to better outcomes. So what happens is the health literacy will then go up because of those years of education. And so it translates into increased self-care behaviors, to lower A1C values, and improved quality of life. And those are the key outcomes that we're looking at with diabetes. So what has the research shown us? With lower health literacy, we know that there's less diabetes knowledge. So that's not fully understanding what diabetes is, perhaps not understanding what is hyperglycemia, hypoglycemia, and the diabetes complications. We know that low health literacy is associated with higher A1C levels. In terms of self-care, It hasn't been associated as much with self-care behaviors, and I will get to that because it's actually very difficult to measure self-care, particularly in research studies. So what has been shown is that low health literacy is associated with decreased exercise and decreased foot care, so foot checking on a daily basis. And I'm putting that with an asterisk because in these studies, it's all based off of self-report. So a lot of research, and I can tell you this because I do research with self-care, a lot of these measures are self-report measures, and that's individuals taking a survey about their self-care behaviors. And so when you're doing that, it's all based off self-report. We know that there are issues with self-reported measures. They aren't necessarily objective measures of exercise and then foot checking behaviors. With low health literacy, there's also difficulty communicating and understanding medical terms. There are a lot of medical terms used in diabetes. We're using them here in these ECHO presentations. And when you're communicating with an individual with diabetes, it's very easy to have those terms slip out because we make those assumptions that people will use those terms and understand them because they have diabetes themselves. But it may be very difficult for someone to use those terms as well as for them to process that information and understand it. And then lastly, there's a lot less desire to participate in shared medical decision. And we know there's been an emphasis on shared medical decisioning, I would say over the last 10, 12 years. And so that's what we're achieving. And it's been talked about in the ADA standards of care that Dr. Dungan went over last week. And so if there's less of a desire to do shared decision making, that does in turn affect outcomes down the road. Next slide, please. So what are their gaps? Whenever you're talking about research, and that's what I'm presenting here today, in terms of low health literacy, we actually have a lot of gaps in knowledge. And so this can be frustrating, especially since you're here to learn about health literacy. So there are some things that we still need to address in terms of research. So that's really understanding more about health literacy and self-care. And part of this is going to come with additional research and additional funding on self-care, but we really need to look at the objective measures of self-care. So doing health literacy and objective measures of blood glucose monitoring, doing this with objective measures of physical activity, whether it's doing it with steps that you can take with an activity monitor or other activity monitors, looking at this in terms of diet, which can be challenging, especially when you rely on food recalls, but really getting a better sense of self-care. There's also the issue with health literacy and self-efficacy. We know the importance of self-efficacy when it comes to performing self-care behaviors, and as well as engaging with a provider and in the shared decision-making process. And perhaps that's what's key, is that the issue is that there may be issues with self-efficacy and their ability to communicate with the provider or feel that they're able to make those decisions in the shared decision-making process. I put here that there are gaps in gender differences. So there isn't a lot of research that we know in terms of gender differences. We know that there are a lot of gender differences in terms of different health outcomes. And I'm saying this not only in the United States, but globally as well. And then I also want to make a particular note that we don't know any gender differences when it comes to non-binary individuals. And this is something that we really do need to focus on in terms of research because there's very, very little research when it comes to non-binary individuals. And then focusing on the effectiveness of interventions with experimental design. So a lot of the research that has been done with health efficacy in terms of interventions, and most of that has focused on technology interventions, which introduces bias right there. If there are issues with health literacy and the intervention itself introduces technology to train the individual and improve health literacy, some individuals struggle with technology to begin with. But the best design in order to help intervention so that we can make that statement at the end that says this intervention worked is to have a control. So we either need to have a control where there was no intervention, it was just usual care, or we need to have another control where you're comparing two different types of interventions. And we don't really have that evidence right there in the literature, and that would be what is most informative to clinicians. And part of that is also the cost effectiveness. And that's always a key part is if we're going to implement health literacy interventions, we need to make sure that we're also doing ones that are very cost effective so that they'll be easy to reproduce and they are cost effective as well. And then of course, factoring in these influence of the environment. So we're going to be having some series of these sessions that focus on social determinants of health and the importance of the built environment, and just understanding the influence of the environment that it has on an individual is very important. Next slide, please. So I do want to very briefly mention that there are different types of health literacy. So there's oral literacy, And so you can think of, if you're in a medical visit, when someone is communicating with you, are you able to take in that information orally? And then you have print literacy. So when I think about the work that I've done with diabetes, you have people giving you information and sharing it in a medical visit. That's the oral literacy. I think a lot of times of individuals handing out patient handouts. You know, here are the things that I'd like you to focus on. Here's the medications that I'll be giving you. Or if you go to the pharmacist and the pharmacist prints out the medications for the new medications you just had refilled. So that has not only reading, print literacy, but there are also times that you have to do writing. Back in the day when you were doing glucose monitoring, you would have to write in your glucose values. Now I know that's not necessarily the case for a lot of individuals because we have the monitors that record all of that information. And then finally, and perhaps most importantly, is numeracy. And so this is where you're understanding and applying numbers. And there are so many numbers involved with diabetes. And so what I'm going to do is I'm going to have Dr. Rao talk about diabetes numeracy. Dr. Rao?
Okay, thank you, Liz, for that great introduction. So numeracy, and Liz had provided a definition, which I think is fine as well as this one. It's the ability to understand and work with numbers. That's the simplest definition as far as it goes. And I've been interested in this for about 20 plus years. Just a long time ago, don't want to date myself too much, but I was working in an ER and almost accidentally gave a child who had croup 100 times the dose of racemic epinephrine. And actually that's been written up as an editorial in a journal, the Journal International Pediatrics in the year 2000. And it alerted me to the fact that, you know, I think that medical school and maybe residency kind of beats the numeracy out of us. I mean, we all, whatever, even if you're not a physician, you had to go through algebra and you had to understand numbers and percentages, but something gets lost along the way. So it's not just our patients, which I'll get to in a moment, it's everybody, including healthcare professionals. So health numeracy is very specific. It's the degree to which individuals have the capacity to access, interpret, communicate, and act on numerical, graphical, biostatistical, and probabilistic health information to make effective healthcare decisions. And I'll talk about some examples of the kind of terms we use with our patients all the time. Next slide, please, Rick. So physician numeracy, if you want to read about it, because I think that you cannot be a really effective healthcare provider or healthcare professional and understand, unless you understand numeracy and are able to convey it to your patients and understand your patient's lack of numeracy. So I think this is important for people to look at as well. Next slide. So here are the basic numeracy skills that everyone ought to have. So counting, something we often would take for granted. So you say something like, well, the nurse is in the third room on your left. Sounds like a pretty straightforward thing, but it's not. Does that count to the room that you're already in? Usually we won't think so. We think it means you move up 3 rooms, but people don't often understand it that well. Calculation, addition, subtraction. I want you to half your insulin dose, your long-acting insulin dose tonight. So you're taking 35 units of Lantus. I want you to take half tonight. See you in a couple of months. Probably not going to work with a lot of our patients, okay? Understanding times and dates. I need you to return 3 weeks from now, exactly, because I'm going to be back here in clinic. Not so easy, right? The better way to do it is actually to write down the date for people. Reading graphs, tables, figures, and measurements is actually a higher form of numeracy that many of our patients do not have. So there's all kinds of things and apps and tools, and people get excited about them. But a lot of our patients just can't use those sorts of things. This is one of my pet peeves. Fractions, decimals, percentages. You have a 50% chance of your cancer coming back. That doesn't really resonate with people very much, right? They hear that, some people hear that as low, some people hear that as high. It's really hard to convey that. Understanding probability, as you can imagine, that's very, very difficult, and higher order skills should not have any place at all in our communication with patients. Then there's the applied contextual skills, performing multi-step math problems, estimation, applying logic, applying in mathematical problem solving, which is needed when you're managing your diabetes or even showing up for an appointment. So next slide, please, Rick. So it's interesting. So Liz mentioned how poor health literacy is across the population. But I think that if you focus down on health numeracy, it's pretty shocking, actually. So I say, I'm going to my clinic from East Cleveland somewhere. They're coming to see us in my clinic. And I know what time the bus is. I don't know if the bus is run on time in Cleveland or not, but I know what time the bus is supposed to get there. I am told how long the trip will take, but I don't know. I can't figure out if I will be there on time or not. So it's something that we take for granted. We process in our heads within a couple of seconds. A lot of our patients cannot do it. So given a bus schedule, 32% of adults, 110 million Americans cannot figure out the duration of a ride, cannot subtract the times needed to show up. And then of course, we complain. So this is the sort of numeracy that's associated with very poor diabetes control. Numeracy affects some populations more than others. African Americans are affected more than others. And I will say, in my own experience, older folks across all racial and ethnic groups tend to have low health numeracy. Part of it is the theory is that they're so far removed from their education and they didn't need it. But also, they have developed clever workarounds their whole lives for not understanding. It's a little hard to hide, some people hide the fact that they're illiterate. And they do that very well after a period of time. They get people to read something. I forgot my glasses. I got a headache. I can't read it. Can you help me fill out this form? There's all kinds of things. But numeracy as well, there are these workarounds that people find. They recognize numbers, etc. So they don't have to figure things out in their head. And I think the senior citizens become quite skilled at that. Next slide. So here's the final part then. So what do we do about it? Now, let me tell you, we cannot, as healthcare professionals, improve numeracy. I tried several times. So I remember we had this is back when I was in Pittsburgh, brought some older adults who, they all had poor health numeracy together, and they had chronic illnesses, either diabetes, high blood pressure, or heart disease, and started to give them, there are numeracy curriculums for patients. There's plenty of them out there. And try to teach them. It is not a very useful effort. It's very difficult, especially when your patterns of behavior and your workarounds are so well established, to go back to grade school and say, here's what a percentage is, which of these percent is higher. And these are the kinds of questions you'll find in a numeracy curriculum. You're told to follow the sliding scale shown here. Sliding scale indicates the amount of insulin you take based on your blood sugar levels. So if your blood sugar is 295, of course, you would take 3 units of insulin, because it's between the intervals of 281 and 330. Now, this seems really easy, but 15% of adults were not able to answer that question. When we think about, from the standpoint of social determinants of health, the populations we care for, it's going to be quite a bit higher than that are not able to answer that question. So how on earth can a patient manage a sliding scale? I know sliding scales are not used that often anymore, but this is something that we have to keep in mind. So what can we do? We can assess numeracy. In the last few years, I don't think that's necessarily always that useful either. So training patients to improve their numeracy is outside the scope of healthcare as far as I'm concerned. One of my patients is a professor of electrical engineering at Case Western, right? He's got great health numeracy because he has great numeracy in general. So if for us to go back to somebody who has a poor health numeracy and say, well, I want to fix this specifically, you're going to have to go to some very, very basic skills. It's like trying to improve spelling or reading for someone at that point in their lives. It's not easy, and it's not necessarily welcome either. The best thing we can do, in my opinion, is not to assess it at the point of care, which can be embarrassing for patients. It can be time consuming, is for you as a healthcare professional to be aware of the problem, okay? Go to the room that has a little red tag on it on your right-hand side, rather than 3 doors down. Instead of telling your patient, take half your dose of insulin if they're taking 35 units, where they have to figure it out, it's 17.5 units at night. Tell them, I want you to take 17.5 or however many syringes full of insulin tonight. That's what you want to do. Don't tell them to come back 3 weeks from now. Tell them to come back on February 16th. Okay, and write it down for them. All right, write down numbers as much as you possibly can. Right? Don't tell somebody that the probability of you having a hypoglycemic episode, if you are on the sulfonylurea, is 18% or something like that. There are ways of expressing that. You can say something like, well, if 100 people take this medication, unfortunately, about 18 of them are going to have a hypoglycemic episode. And then they can figure out if that's a risk that's acceptable to them or not. So, and I don't expect you to know all of these tricks. There's a lot of literature around it. There's a wonderful article in Health Affairs about low health numeracy and its impact on health and well-being overall, and what you can do with graphs, et cetera, to get around it. Unfortunately, I think, even though I've been part of the evidence-based medicine movement, we have really not done a good job. This idea of number needed to treat, if you treat 100 people, they'll have 3 fewer heart attacks. That might be useful for our patients. Don't really understand that. They want to know visually or numerically what their chances of having a specific event are. And so there's a lot of workarounds, but I think, for the purpose of diabetes, just keep in mind that a lot of your patients have low health numeracy, and there's nothing wrong with assuming that all of your patients do, because, in my experience, people aren't going to be offended if you tell them, yeah, I know how to figure out insulin doses, or I can use fractions and ratios, no problem. If you just tell them specifically, it doesn't stigmatize anyone whatsoever if you have a standardized approach to how you explain numbers to your patients. So next slide, Rick. Okay, thank you. I think we have a few minutes for questions for both Liz and myself.
So maybe I'll start off with one question. One of the techniques that the CDCES, the new term for diabetes educators, have often used or tried to use is the teach back method, and that maybe might not only assess but also help to educate if someone can learn some of these concepts. What do you think about that, and do you use that in your practice?
So I can comment. So I do a lot. Here's an example of how you would use it. Tapering medications. I want you to take, you don't want to stop a medication. This is not in the context of diabetes, anything. You don't want to stop it suddenly. So I want you to take your dose every second day for the next week and then stop entirely, whether it's Coumadin or whatever it happens to be. That's one way of expressing it. And then you can express it that way. And people will nod politely. But if you want to do a teach back, it's really useful and say, okay, well, today is Thursday. How much are you going to take Friday? You take 1 tablet on Thursday. How much are you going to take Friday? And the correct answer is you don't take anything on Friday, and then you take a pill on Saturday, et cetera. So you can assess their ability to understand that. If they start to say, well, I take the same dose Friday, you know that they have no idea exactly what's going on. And rather than explaining it again, okay, remember, numeracy is something that is part of their lives for 60, 70 years. You're not going to change it, which I think is something people beat their heads against. Don't worry about that. Say, okay, well, that's not right. You don't take another tablet on Friday. I want you to skip each day. So here's what I'm gonna do. I'm gonna take a little piece of paper. I'm gonna write down the days, and I'm gonna put take on Thursday, not take Friday, take on Saturday. I'm gonna write it out for you, because I'm not trying to improve your numeracy. I'm trying to work around it. I'm trying to accommodate your low level of numeracy. So that's how I would use the teach back method.
Liz, I was curious if you had any other thoughts on, ways of getting around literacy. Well, I suppose numeracy as well. When we talk about diabetes self-management education versus school education, what I'm hearing, I think, from both of you is that if we don't have the skills in school, or that you've obtained throughout your lifetime, that it can be very challenging for diabetes self-management education to move the needle. Or how does that work?
Yeah, that's a great question. So one of the important things, and this isn't necessarily an answer to your question, it's just the distinction that I didn't mention earlier, that health literacy is very distinct from intelligence. So you can be incredibly intelligent and still struggle with health literacy. But you can also have problems with health literacy. Um, so it's not specific to your intelligence. However, the more education you obtain, it can mediate that relationship. So that's one of the things that you could look at, is just encouraging people to have education. But when Dr. Rao was saying, having these older adults, it makes me think of my grandparents. And, I have grandparents who did not graduate high school, or they, in the past, they hadn't graduated. And I can think of, had they been on these medications, they would have struggled. But they also, if you had done the teach back moment, they also would have said, "Oh, I understood you, I'm fine." They probably would not have shared it. They would have hid that. So in answering this, it's a very tricky thing, because it's not like you can go tell people to get more education. People are in different phases of their lives. I think I would have to go with what Dr. Rao was talking about. And I think just the easiest solution is to provide that information. And I'm not sure that answers your question, but giving the answers directly to the individual.
That is very, very true. It's very surprising to me, if I try to describe a more complex topic, how often I will hear "okay," and then you come back to it, and there really wasn't that level of comprehension, and you would never know unless you did that teach back. Chris Taylor made a comment. Dr. Rao emphasizes an important point about comprehension assessment, of them having to explain rather than to confirm understanding. Yeah, I think it kind of, what you're saying is echoing that.
Yeah, and I just want to add, it's very hard. I think Adam Przinski, and I believe Adam's on the call this morning, made the point that it's hard to recognize what someone with low health numeracy looks like, or low health literacy. And I think he pointed out some executive who failed some numeracy test last year, and everyone was shocked by that. But Liz makes a point. It's not related to intelligence. It's our patterns of education. It's our background, etc. And so you can have someone who's very articulate and very well groomed, who may have low health literacy overall. The one consistent finding, however, is it's not gender. It doesn't seem to be an issue. Race and ethnicity, not much of an issue, except in the younger population, 18 to 65-year-olds. There is a disparity in health numeracy between African Americans and the general population. However, it's age that seems to be a determining factor in health numeracy, meaning your senior citizens, who are the ones we care for most, who have type 2 diabetes, who have chronic illness, are likely across all race and ethnicities and even socioeconomic statuses more likely to have low health numeracy as well. So they are the vulnerable population. And it probably does have something to do with numeracy actually declining as you get older, as you get more detached from education, and for the need to use sophisticated numbers as well. So that 75, 80-year-old patient with chronic illness is more likely to have low health numeracy and does need additional help. And as Liz said, just write things down for them, make it very explicit, even if it's entirely obvious to you and to the grandkid who's there with them. Write things down. It saves them from being embarrassed or shy about the issue, and it makes helps you take better care of your patients as well.
Go ahead.
Kathleen and Goutham, this is Jim. Can you hear me?
Yeah.
The other thing is, we make diabetes care so complicated sometimes. Patients come into me, complicated regimens, you simplify them. We have great tools to simplify. The example of warfarin, you switch them to a DOAC. In diabetes, you can switch a lot of regimens. And sometimes we make it so complicated, the disease and the treatment, patients have great difficulty following it. A few simple changes to simplify the regimen, and it gets much easier for the patient. They don't seem overwhelmed by the disease. So I think it's often good to step back and say, should I change this regimen to make it simpler in a patient who has difficulty understanding complicated directions?
Yeah,
And
that's a good point. Go ahead.
I wonder if, you know, that patient who is on a complicated regimen, if, you know, if just even asking them to explain how you decide how much insulin that you take could be eye-opening, because sometimes I just can't, you know, get it out of them how they decide, and maybe that's part of it.
So I just want to, Jim had there's a number of great points coming through, but Jim had an important point about teach back, and you know, and we'll cover this later on in the course. You don't want to say something like, now, go ahead, tell me what I just told you in a rather confrontational or condescending manner. It's more, you know, as he said, you know, just to be sure that we're on the same page, or that I've explained this well. So put the burden on you. Can you tell me how much insulin you would be taking tomorrow, or how much metformin you'd be taking tomorrow? Because we're starting to ease up on the dose, or we're increasing the dose, just so that we understand that. And that makes it a lot easier. And as I said, if they don't understand, don't go back to your numeric explanation, which will take you another 10 minutes of your 15-minute appointment. Say, no, that's not correct, but I'm going to make things easy. I'm going to write the days, and I'm going to write things down for you.
Yeah, there's some great comments here. A couple of Pam Murphy had suggested, you know, getting a family member involved. That might also be a way to kind of help bridge that gap there. Establishing rapport, not report.
Hey, can you hear me? I have a few examples, if I may share, of what went wrong, if you will, in trying to address numeracy. Hi, I'm Melissa Thomas from Ohio University Heritage College of Osteopathic Medicine. I've worked with Amish and Mennonite communities for the last 2 decades. And one point I wanted to make is that sometimes what we say makes such sense, but it really is quite confusing. And I've learned that, especially when English is not a first language, this also adds additional barrier to numeracy. Starting out talking with the Amish and discovering a higher death rate from breast cancer, we started educating and sharing again the same tips you learned. And I remember sharing with the Amish that, you know, we asked them in a teach back point, talking about the risk of breast cancer. Of course, then the statistic was 1 in 8. But many Amish would say, well, I think the risk is 1 in 100. And so we initially thought that the Amish were underestimating breast cancer risk. But when we asked them and took additional notes on the interviews, we found that many Amish were saying, well, I think the risk of getting breast cancer is high. I think it's 1 in 100, a very common, right, numeracy issue. I also remember sharing the statistic that, well, you know, over a lifetime, for 8 women, you know, 1's going to get breast cancer. But the response back from some women was that there's 100 people in my church and nobody has it. So I don't think it's a big deal in our community. One quick other fact, I remember that in our early education, we shared with women that, of course, if you have a lump in your breast, this is a big concern and that you should get it checked. However, if in fact you do find a lump, not to be too concerned, because over 80% of the time there's not a risk. So we would have Amish women say to us, well, I mean, the odds are pretty good, nothing's wrong. So we're not going to worry about it. And I think sometimes, even in our best efforts in communicating, we provide mixed messages in some of our communication that summed up still don't really convey what the concerns are. So again, a non-diabetes example, but I think we become very intentional with using visualizations and also providing different examples of how we communicate that risk in certain diseases.
Terrific, Melissa. Thank you for those examples. And there's lots of examples from outside diabetes care. I was seeing patients yesterday, and I asked an older patient, most of my patients are older, and she asked her, are you going to get the COVID-19 vaccine when you're eligible, which I think is now, she's now eligible. And she goes, no, I don't want to get it. I've heard about terrible side effects and allergic reactions and that sort of thing. And she asked me, did you get your vaccine? I said, yes, I did. I got my first dose a couple of weeks ago. And she goes, aren't you worried about side effects and that sort of thing? And then rather than using numbers, which I knew would not be compelling, I said, you know, I am worried about side effects and the effectiveness of the vaccine, but I'm much more scared about the illness. And then I talked about the complications of COVID-19 and what I've seen in people, you know, the 45 to 54-year-olds who, one of them was my friend who's a chair, who's still having symptoms months and months later, and said, that really bothers me. And that's what I'm scared of. So I remember consciously in that whole discussion, which took about 10 minutes, not using a single number. I didn't convince her that she should get the vaccine, but I think I was able to at least explain myself in a way without using percentages and ratios and probabilities. So.
Yeah, there are a couple of other comments in the chat and then we can maybe just move on to our case. I thought this was good. Stephen Swedland suggested, you know, always think about cognitive screening or the mini cog test, you know, especially I guess in our older adults. And then Katrina Roy also suggested kind of a similar thing when a patient is having to change a dose or do something different on different days is instead of moving the sites daily, write out a plan of where they should apply the patch, do the injection, something like that. And another person wrote that they would print out a calendar and write out what specific days they should be taking what dose. So those are all really interesting, great feedback. Okay, so could we put up the case? Well, we'll open up this case to further discussion. There are just so many angles in this case. It's very, you know, very interesting. I think, you know, first off, I guess I'll just start with just this dichotomy between the A1C and the self-reported measures. Sometimes I wonder if that's just, you know, people are monitoring when they know they're kind of doing what they feel like they should be doing. And so we get sort of that mixed bag. She might be somebody that might need, you know, might be super carb sensitive and, you know, maybe not need a lot of basal insulin. But gosh, you really do feel like you're in the dark here. My guess is that she's high more often than she knows, especially with 15. I mean, I guess the other thing to consider is that the A1C, about 50% of that A1C is accounted for by the previous 30 days. And though we think of it as a 3-month marker, it does tend to really represent the most recent month. You know, if I've got somebody that I know has had recent improvement in blood sugars because of whatever, I'll sometimes do a fructosamine. There are other tests like glycosylated albumin that you can do that can maybe give you some clue as to, you know, is this short-term or not, because we don't really have, unless you download her meter, recall bias is just that. I think people overestimate how often they check their blood sugars. Mm-hmm. Any other thoughts? Somebody says, I would check for anemia, ask about steroid use through these illnesses, consider repeating the A1C as it doesn't match what the patient's reporting. Did she look at her meter? Yeah. You know, another thing, if they're not on insulin, you can also do professional CGM, but you may not have that capacity at your practice.
Yeah, I was just going to comment that we've been doing some back and forth around her insulin over the last few days, and all of her blood sugars are matching. You know, now that, you know, it's just interesting, you know, once she heard her A1C was 15, and then all of a sudden she was checking her sugars and they were, in, you know, 300s, you know, so I don't know. It just was sort of interesting that you told me that was 100 and that sort of story beforehand. And maybe you're right. Maybe it was a recall bias and it was from, you know, a few weeks before that, or, you know, it just was so, you know, it was set as, you know, in a way that it was, you know, that week before. So it was just interesting, but her meter is matching, you know, sort of the A1C values right now.
Oh, good.
Just so now that we've had the conversation about the A1C.
Mm-hmm.
Sherry, does she drink alcohol? I don't remember if you mentioned.
She's not drinking right now. I mean, I don't think she's drinking right now based on what she has told me. I guess I'm not watching her at home, but I don't think she is.
Okay.
It seems like an interesting juxtaposition with her work schedule, that she's got a lot of those compressed days, but she has a lot of other kind of flexibility around that. I know with having kids at home and most likely school at home and things like that, it becomes a little bit more chaotic. But when things start getting back to normal, it gives her some capabilities to start kind of prep for the week. And especially if others are working, you have the ability, being able to kind of pre-prep meals ahead of time for the week. It allows them to kind of find more cost-effective ways. You can throw together food on Sunday and have things prepared for what Monday is, what Tuesday is, helps to address some of those and kind of start that planning process of, so what are the carbs that I'm consuming? What are these sources? Oh, I got a lot on Monday. Maybe I should put some of these on Tuesday. And then just providing that reassurance from the primary care provider side to say, yes, we think diet is important, but I think this is a very important aspect for you and creating a priority for them. It's like, I'd like you to go see him. As, oh, okay, that's nice. No, this is something that's a priority that I think is going to be necessary to improve your care. And again, it's another one of those scenarios ad nauseum. We have multi-generations within, which ultimately creates an opportunity. Maybe it's a family meal prep time. Maybe it's family walking time and things like that. So the ability to kind of pull others in so it doesn't just become a sole responsibility, but it could then start to become more of a routine than it is, oh crap, now it's 6 o'clock and we have to eat and I've got to work tomorrow and everything else. So planning forward in that regard.
Yeah, that's a great point. I was on the phone with her before this is a couple months back, where she was picking up fast food, and while she was on the telemedicine call with me, and and she was sort of made the comment that this is for my husband. It was very interesting. So I didn't get into it at that point in time, but clearly engaging around some of this and for the family. Interestingly, her son developed type 1, which she calls type 1 diabetes. I think that's because all of them are on insulin, like around age 10, and her granddaughter is also on insulin, developed that in her teens. And so the son is obviously now older, the granddaughter is still in her teens. And her daughter, who does not have diabetes, is there at the house and was helping her with her sugars over the weekend and the insulin dosing. And so that was actually a real positive in terms of, how to manage it. And so I think there was definitely ways to bring in support, and also the importance of the whole family.
And someone has, Pam Murphy has mentioned that a question about bus drivers. Is she a school bus driver or, like a
City bus?
Commercial? Okay.
Yeah, city bus driver. Yeah, and so I don't know. I know in the past there has been some issues of whether you can still be a bus driver if you're on insulin. I don't know if anybody knows.
Yeah, so I was just looking at that, Sherry, because I thought it was a fascinating question that you raised. I just was looking online, and the answer is yes, you can be a commercial bus driver. If you go interstate, apparently there's different rules because every state has different rules. But you have to have had no hypoglycemic episodes documented medically in the last 12 months. You have to have a readily absorbable glucose source while you're driving a bus, and you have to have your insulin with you. But I think that she probably could be okay. I'm just thinking there must be so many of our bus drivers with type 2 diabetes who are on insulin. I think if we excluded them, it would be a big problem. So.
A bigger concern is often for, as a former commercial driver, something most of you probably didn't know about me, and specifically
that was airplanes though, Adam, right?
Specifically a transit bus driver. The one thing that a lot of times screens people out of the health screening is actually high blood pressure. It's like a super common reason for commercial drivers to fail a health screening or health eligibility. And Yeah, the insulin and blood glucose they're far less common. They're usually a little bit more understanding about that, but the blood pressure is like a no-go. In fact, I actually know a physician in Akron who runs what could be described as like a commercial driver hypertension clinic. like where he just sort of has a steady stream of commercial drivers who need to get their blood pressure under control so they can keep their job.
Yeah, surprisingly, I've got commercial truck drivers, school bus drivers, and other bus drivers that can drive while taking insulin. You do have to fill out forms pretty frequently. I believe it's every 3 months, but I may be mixing some of them up. And you have to certify that they've not had significant hypoglycemia, and I believe also hyperglycemia. So, at this A1C, you'd also be concerned of her ability to drive a bus, her vision, all of that at this A1C.
Yeah, she's on short-term disability for her shoulder for the next month. So that's actually good timing in terms of just not working so that we can get this under control before she ends up going back.
Yeah, another thought that, there are some case reports of sudden worsening of diabetes with COVID-19, and could this be part of that? And certainly there's an enormous inflammatory response, and that has, a direct, correlation in terms of insulin sensitivity. And so I don't know if this far out you could be seeing that, but yeah,
Have you seen, Kathleen, some people with all the, not necessarily the COVID, although possibly, but the other recent illnesses she's had? Do you put people on insulin and then end up having to back off? Is that something you've seen?
Yeah, very commonly, especially if someone's had a major surgery. They often, like, cardiac surgery is a pretty classic case where, there's like a 6-week recovery period, and the majority of the time they're clearly needing insulin at discharge. And, within a month or so, they're completely off of it. Okay, well, we're at the top of the hour, so I am going to hand it over to Jessie for our wrap up. Thanks, everyone.
Great. Just a couple things before we close. Just a reminder again, you can watch the recordings of these clinics on our website. For the current series, you will need to make an account with cardio.org, but you can also watch any of our previous cardio TeleECHO clinics there as well. Next slide, please. You should have your post-clinic survey in your inbox now. Just a reminder that those survey links will close tomorrow at 5. So if you could please fill those out, those are very helpful to us. And then lastly, we just wanted to let you know that Cardio is also hosting a webinar February 10th from noon to 1. It's free to attend, CMEs are available, and you can register on our website as well. So I know we're a little bit, just a minute over time, so I want to thank you very much. And next week, we look forward to our topic, lifestyle approaches to management of type 2 diabetes with Chris Taylor. So thanks, everyone. Have a great day.